My name is Heather Kronis-Danek. I'm the Senior Director for Individual Giving for the Eye and Ear Foundation. Today, I'm really honored to introduce my friend, Shaum Sridharan. I always just call you Shaum. He is an associate professor of otolaryngology, and we're going to be talking about salivary stones. So since we're running a couple minutes behind, let's just jump into it.
Well, thank you guys for inviting me. Really appreciate the invitation. The Eye and Ear Foundation is a wonderful organization, and it's an honor to be able to speak with you guys. As was mentioned, my name is Shaum Sridharan. I'm one of the faculty in the Otolaryngology department who specializes in head and neck cancer surgery, reconstructive surgery, and in salivary gland procedures. So today I was going to talk to you guys about salivary gland sparing surgery and the role of Sialendoscopy. So I wanted to say there's no disclosures. I wanted to thank Barry Shakin for his mentorship. He was the Sialendoscopy guru who passed along his knowledge to me, and I've sort of taken the reins from what he's built over the course of his career, really. And he was an early adopter to the technology and a real mentor to me. So what do I mean by salivary gland surgery? Or gland-sparing surgery. So salivary gland-sparing surgery involves the ability for us to intervene on the salivary glands without destroying their function. Basically, we're able to use minimally invasive techniques and novel treatment strategies in order to help maintain the function of the gland while still being able to remove tumors or remove stones or change the function of the gland after sequela from other treatment, which I'll explain later. So on the screen here is the sort of the biggest highlight of the talk is this camera, the scope here. This long instrument here is really the most novel new technology that's come out in the last couple of years. So this is called the Sialendoscope. It is a telescope that is able to be fed into the salivary gland and has multiple channels, and we're able to feed instruments through these channels and intervene in the gland. And we can see, though the images are small, we are able to see within the salivary gland and to use interventions such as balloon dilation or stone removal or even laser through this instrument. I highlight here on the bottom left, a stone here that's within the salivary gland that is being treated with a laser. And then down below on the bottom right is Botox, which many of us know from the cosmetic side of the world, but can also be used to turn off the salivary gland and to reduce the sequela of some of the chronic inflammatory diseases that we see. So I wanted to talk a little bit about the history and the case, anatomy and imaging, and then go into some of the nitty-gritty of procedures that we can do. So I wanted to present first a case of a 56-year-old male who has a history of hypertension and acid reflux, and he presented with right-sided neck swelling and pain with meals. Now imagine this is very uncomfortable for a patient to have repeated neck swelling every time you ate. It would be very difficult and painful, but also hard to have meals with other people as you saw the neck swell up and have a difficult time with even the cosmetics of having one side of your neck being larger than the other. So on the scan here, this is a CT scan. There are several stones in this circle here. So this is that submandibular gland, which is I'll explain as one of the major salivary glands. And here it's peppered with a bunch of these lucent stones. Now these stones are the ones that cause obstruction, just like any other pipe would. As this salivary gland tries to shoot its saliva into the mouth, these stones are actually obstructing the gland and causing it to back up, just like a clogged toilet. So he was told by another otolaryngology, actually two other ENTs, that the best thing for him would be to have his submandibular gland removed. Now, he did not want to undergo a surgery like that, so he saw me for a second opinion, and he was actually referred by one of the otolaryngologists. I'm going to come back to what we did for him at the end of the case, but I wanted to start with that kind of treatment dilemma. So these are the major salivary glands. I kind of wanted to go back to the basics. So this is called the parotid gland, which is on the side of the cheek right in front of the ear. Down here is another big gland called the submandibular gland. And then here's the smallest of the major salivary glands, which is the sublingual gland. There's also minor salivary glands, which are very, very small, that are all throughout the mouth and the throat, that also provide saliva, but these are the major salivary glands that we deal with. As you can see, this nerve coming out is called the facial nerve, and this nerve supplies the innervation to muscles across the face to get the face to actually make movement like smile, raise your eyebrows, close your eyes type. So this is just to illustrate that the glands are in the sort of this danger zone where you have these nerves that are coming across it and must be dealt with when you want to manage pathology within these glands. So a little bit of history, the parotid gland has been, described for many years, but it wasn't until the 1600s when this gentleman, Nicholas Stentonius, was the first to understand that there was actually a tubing, a duct that went from this salivary gland, the parotid gland, into the mouth. So he actually was dissecting sheep, and he saw that there was an opening that nobody had described or understood, and started probing this duct and this opening, and then found that it actually connected to the salivary gland. So it's called the Stenson's duct. It's about 3 millimeters in width, and it crosses over this big muscle here called the masseter and goes and enters into the parotid gland. The submandibular gland, the second biggest of the major salivary glands, was described by a gentleman named Thomas Wharton in 1659, and it's about 5 centimeters long, and it's about 4 millimeters wide. So both of these are very small in size, and importantly, this duct, this piping, is actually crossed by another nerve, which is called the lingual nerve. This complicated diagram on the right-hand side shows the floor of the mouth, just between the teeth and the tongue, where the duct sits, and the lingual nerve actually traverses across the duct and is important when it comes to understanding how we can intervene without causing too much morbidity to the patient. The last one is the sublingual ductal system. This Bartholin's duct is what connects it to the oral cavity, and this one is not able to be navigated, much like the other two will be, and I'll explain that later with the Sialendoscopy. So when a patient comes in with salivary swelling, and we don't have a clear diagnosis of what's going on, the differential diagnosis is huge. I only put this slide on to talk about the fact that we are thinking about a lot of different things, and not everybody that has salivary gland swelling is really having stones or something obvious. So we have to be thorough doctors and really think about what it could be. So the most common reason why I get referred patients is salivary stones, and the medical term for that is called sialolithiasis. So these stones are usually kind of yellow in color, as seen here, and this is actually a picture from that Sialendoscope where you put it into the duct, and this stone is obstructing the duct. It can obstruct the salivary flow, but sometimes it's too small to obstruct the flow, or it's in a position where it can jostle around, and it can cause intermittent symptoms. The size of the stone matters, not only because of its tendency to obstruct the duct, as we were talking about, it's 3 or 4 millimeters for many of these ducts, and it also matters what approach we use to remove these stones, and I'll explain that later. And the location of where the stone is also matters, and so if it's very far closer to the mouth, then that's a different type of approach, whereas it's inside of the gland, then that's a different type of approach. So it's not very common, but we tend to see a lot of it here at University of Pittsburgh because there's nobody else taking care of these patients for quite a long way. So probably the closest place that's taking care of patients this way, in this manner of minimally invasively, is probably in Cleveland, and then all the way over to Johns Hopkins. And in between there's not that many places that will feel comfortable doing complex cases of salivary stones. This idea that you can have stones, but it's not necessarily going to cause symptoms is represented by autopsy studies, which show that it's about 1%, which is higher than this 1 in 15 to 30,000 people incidence of stones. So these stones are made from hydroxyapatite, from magnesium, from calcium. They're just made up of a lot of different substances, but they're firm and they're hard. You can crush them usually once you take them out of the body, or with a laser. You can ablate them, but they're pretty firm and they do cause symptoms. They're not like typical stones like you see, and in the playground, but they are these yellow, firm, ovoid masses that cause the obstruction. Usually we diagnose these salivary gland pathologies with history, but also with imaging. So, plain film imaging is difficult to interpret sometimes, and sometimes they're not as readily radio opaque. So most of the time we're going to be getting CT scans, especially when we suspect stones. So these can find stones that are quite small, but sometimes they're not radio opaque, and sometimes the stones can be even smaller than can be detected on the CT scan. And so a lot of it sometimes is based on the clinical picture and the mealtime obstruction and some history of whether they've had stones before. Here's an example of a CT scan and how much information you can get from it. Again, these lumps here are the submandibular glands, not the parotid, but the submandibular glands. And these big chunks here are stones that are within the gland and are readily obvious. Here it is the actual tubing. The tubing, once it's obstructed, everything downstream of it gets very swollen. And so it's just like a hose that's gotten bigger here, and that can give you clues that there's an obstruction somewhere up here because the flow cannot go past the obstruction. A sialogram is another way to image patients. You actually have to inject contrast into the duct and back through the salivary piping into the gland, and you can see the architecture of the tubing and how complex it can be. This is great. It can diagnose where there's a sudden stoppage, maybe because of a stone, or it can show where there's an area that's narrowed. So this is really valuable. I recently had a patient that had a injury to the duct that I assumed was a full injury, a complete transection of it. But to confirm, we did a sialogram and it showed an abrupt stop and confirmed that this was an injury from a dental procedure. And so we would have to take care of her and open that up. These are challenging to perform and read, so not as commonly used. Probably the most interesting, but sort of more less commonly used technology is MR sialography. This is probably less done because most of the time people use the endoscope itself to assess the gland, and also CT scan is quite good. But in a pinch, or when things are really not making sense, I think an MR sialography is very good. You can get this scan here at the University of Pittsburgh, and it's usually done with coordination with the radiology department, and it uses the natural texture of saliva to sort of identify how the salivary flow is basically being inhibited or where it's pooling, and can give us a lot of information. Basically, this was studied by one of the godfathers of Sialendoscopy, Marshall, and he noticed that in 64 of these glands, it was very accurate, both for stones and for strictures, as I had mentioned before, as being the two very common reasons why people get these backed up pipes. In-office ultrasound is one of my favorite ways to assess patients. Ultrasound is cheap, it's easy, it's in the office, can be done on the same day, and can find stones, it can find dilated ducts, and it's really great as an adjunct for when we're actually taking out stones to have a visual representation of the stone from both directions. One is tactile from the mouth and then from the neck, so that we can really what we call sonolocate these stones, and we're able to remove them. The patients love it too, because you can give people instant feedback and show them right on the screen, right in front of them, what you're thinking. It can pick up masses. It can pick up signs that there's chronic inflammatory disease. So to me, it is underutilized in the U.S. and we try to use it on all of our salivary gland patients here in our clinic. So as a summary, CT is best for inflammatory diseases, as is ultrasound. The MRI is good for salivary gland tumors and with silography, but much more commonly used for salivary gland tumors. And then ultrasound in the right hands is going to be a winner for many of these situations. So again, this is the Sialendoscope. So this has been developed over the course of about 2 decades from a very primitive sort of mechanism to what we see before you here with these multiple channels, the camera here, and the ability to see what's going on inside the duct on this screen right in front of you while you're operating. So as a little bit of a Sialendoscopy history, in 1991, people were using nude fibers, and people were trying to introduce lithotripsy, which is physically sending shock waves through the stone to try to break them up, which is effective, but is much less commonly used in the United States because of FDA approval versus in Europe. Marshall, again, one of the major leaders in Sialendoscopy, developed this Karl Storz set and wrote a New England Journal paper on the state of the art in 1999. Zenk and his colleagues were able to create a semi-rigid scope in 2004. Slowly, things are getting better pixels, higher pixel rate, and definitely better images. Soon, the rigid endoscope is sort of introduced in 2006, and Barry Shakin, being one of the early adopters, started using this very early on in the infancy of Sialendoscopy, and has seen all the adaptations of the Sialendoscope, and people really started to catch on after this 2009 paper where almost 5,000 patients were treated using this Sialendoscope technique. This procedure can be performed in the operating room or in the clinic. Sometimes people do it under sedation. Some people do it under general anesthesia. You can utilize the working channel and the irrigation channel, which is nice because you can feed larger instruments through the working channel to actually get stones and other things out of the patient's body. And then you have varying sizes of scopes, but they're all very fragile. You have to be very careful. The slightest of bends can break the camera or make the picture unusable. So it is a very delicate system. I wanted to show you how we enter into the actual duct. You might think, well, these are tiny little things. How do you actually get it? How do you get this camera through? And basically, we take these dilators and sequentially put it into the puncta, the opening, into the gland, or into the duct, and we can slowly dilate this. This process has to be done with care. If you do it the wrong way, you can create a false passage, and you can cause more trauma to the duct and more stenosis. So here's a video of this dilation procedure. We slowly find the duct. This is the submandibular gland. This is us entering it. Here's the teeth in the front. So this opening is right under the tongue, just to the right and left of the midline. And so slowly you can put this dilator in and enlarge it one by one. And by doing so, you can get it big enough so you can put the camera through. But even this can be a challenge. And I always think that this procedure can either be 5 minutes to do this procedure, or this could take a lot longer. You have to pull out all the stops, including using methylene blue and compressing the gland to try to see if you can see any outflow. And on rare occasion, you can't get into the papilla, and it just you have to stop, and you have to talk to the patient before surgery that this is a possibility. So there are a lot of instruments that you can use in conjunction with the Sialendoscope. You can use dilators and bougies to kind of get it as big as possible. You can use a wire basket to go retrieve the stone and trap it. You can use forceps and graspers. You can use a laser, and you can use a balloon dilator. So there's various things that can go through here. So people the new instruments are being developed all the time, and so we're trying to use what's the latest and greatest to try to help our patients and maintain this minimally invasive technique. So for the way that we think about, or the way I teach the residents is, the size and the location of the stone really, really matters. So basically, for stones that are small, less than 5 millimeters, less than 4 millimeters, depending on who you ask, and the right shape, you can often remove these just through the endoscope. So you can put the endoscope in, feed a wire basket through, and pull the stone out and get it out. And it's minimally invasive because you don't have to do much to even no cuts in the mouth, no cuts on the actual opening. You can just get the stone out. In some cases, you can actually grab the stone and position it so that it can be in a better position. So if you do have to make a cut, it is in a safe zone, away from that lingual nerve, as we mentioned before, and in a place that won't have as much downstream sequelae. So here's a video of a stone. I'm going to fast forward just for the sake of time through some portion of this. You identify this stone within the duct. See, this here is the duct. You can see how this stone, if it's put in the right position or in a distal aspect of the duct, can block this. Here's the feeding of the basket past it. So once you feed it past it, you can trap the stone and you can, as you can see here, we've trapped the stone. We're going to cinch onto it by using the lever on the basket. And once you do that, you can pull it out and safely remove it either through the natural opening or make a small cut down and remove it. You can cut right onto the basket itself and remove it. So for medium-sized stones, I would say you can repeat the same type of procedure where you can use the basket and cut down, or sometimes you have to, if you can palpate the stone in the floor of the mouth, you can actually make a cut and take it out that way. But the endoscope is so valuable because you can actually follow the duct. Even after you've taken the stone out with an open approach, you can follow the duct and make sure there are no other stones. Because if you leave other stones behind, that's when you run into a lot of problems, and that's when you have to do a revision surgery on the patient. And as somebody once told me, I'm pretty good at surgery, but I don't think there's many people that are very good at revision surgery. So it's best to do it right the first time. For large stones, you often have to do a combined approach where you have to utilize the sialendoscope and open surgery. And this is demonstrated the most in the parotid gland. The parotid gland is very difficult to remove stones without having to make some kind of cuts, unless it's the perfect case and very small. But through this combined approach, you can still maintain the function of the gland and you can make strategic incisions on the patient in order to remove the stone and get the best of the gland without having major cosmetic deformity. So first, I'll talk about the submandibular gland. Here is the lingual nerve actually in the floor of the mouth on a patient of mine. This is an arrow kind of pointing to that nerve. So when you do make this incision in the floor of mouth, you got to be careful of that nerve. And sometimes you have to actually move the nerve out of the way in order to get the stone out. So you isolate and retract the lingual nerve while the assistant kind of pushes everything from the neck, and you can get the stone out. It's only a 2-centimeter incision and usually does not cause any difficulty with speaking or swallowing. Here's a 1-centimeter stone I removed on the right side here from this sort of approach. The parotid gland is more complicated. So for the parotid gland, often we have to put the camera in through the mouth. We drive the camera to the area where the stone is and we transilluminate. We show the light here. Once we can see that light, we make an incision in front of the ear and around the neck, sort of like a facelift incision. And we're able to raise the skin up until we get to that light. The reason why we don't make a cut directly over the light is because that'll cause a scar on the patient's face. So we'd rather have this incision that's much more hidden in order to have the best cosmetic outcome for the patient with the same equal outcome with the removal of the stone. once we raise this up, we're able to make an incision right over the stone and over the duct and open it up. Once we open it up, this is the view of the of how we. This is the approach that we would use to access the duct. Once we identify the stone and the light, we can make an incision there, remove the stone, use the endoscope to make sure there's no other stones, and then you can actually close the duct using microsurgical techniques with a very tiny needle, and you can either patch it or you can close it completely, and sometimes you can even place a stent that stays in for a couple of weeks to maintain the patency. Then you can do a complicated, multi-layer closure to make sure that no saliva leaks out of the wound. And this is the standard approach for larger parotid stones, especially ones that are not very, very close to the very front by the mouth opening for these patients. So sort of as an algorithm here, it's small, tiny floating stones you can take out just through with the camera and with the instruments. For medium-sized stones, sometimes with the camera, but sometimes you have to pull out your bag of tricks with the baskets and with minor cut downs in the submandibular gland, with lasers sometimes in the parotid gland, or in a hybrid approach. And then for the large stones, you got to use that hybrid approach where you use the endoscope and the incisions in order to remove the stones. So if this is complicated, why not just remove the gland? Why not just take out the tissue? Why do all these minimally invasive things? And the answer might be, well, of course you should do that. But just to put a bow on it, this is the incision that you would have to make to remove the submandibular gland. So there's definitely a scar. You would raise up the skin and you have to remove the gland. But as you remember, the facial nerve runs right over the gland. And so it is not uncommon for that nerve to have to be dissected and removed moved out of the way in order for you to get the gland out. So you can have temporary or permanent facial nerve weakness from the operation. Also, there's a risk of hematoma and abscess. There's a risk of lingual nerve injury because the lingual nerve is on the deep aspect, as well as the hypoglossal nerve, which is the tongue movement nerve, which is the hypoglossal nerve, and the tongue sensation nerve, which is the lingual nerve. So you really don't want to be messing with those nerves unless you really have to. This is what we do day to day, is do these types of operations. But if I were a patient, I'd much rather not have the incision on my neck and the risk to the nerves in my facial nerve function. So this is an example on the right side of what happens when you have that lower division facial nerve injury. This is that marginal mandibular weakness, which is hard for patients to have this lip not kick out as much. So when you smile, this lip is not moving as much, and so patients can bite on their lip. They don't like, some of the cosmetics, and sometimes this is very, disturbing to the patients, and it's something we'd like to avoid if we can by doing these minimally invasive techniques. When you do have a stone that's within the salivary gland, your hand is a little bit forced. You sort of have to remove the gland. This is much more common in the submandibular gland than the parotid gland. It's rare to have to remove a portion of the parotid gland unless there's a chronic inflammatory process that's different than a salivary stone. And in those cases, you have to, again, put the facial nerve at significant risk, but this time all the branches of the facial nerve, and it's much more common to have facial weakness in that operation where you have to do a total parotidectomy. And so we like to avoid doing major gland operations unless we really have to. So non-stone problems. So issues that often arise that we can use the Sialendoscope and these minimally invasive techniques are things like stenosis, which is a narrowing. And here's a sialogram here, and you can see this nice patent duct and then a sudden narrowing. These narrowings can cause a lot of symptoms. So this is one reason to treat with Sialendoscopes. Then you have Sjogren's disease, which is a autoimmune disease that affects the whole body, but can really affect the salivary glands. Scar, like the dental injury that we talked about, that we we would need to traverse that scar and identify how to open up that duct. Recurrent keratitis in a juvenile, and then post-radioactive iodine. Radioactive iodine is used for thyroid cancer, and so for after thyroid cancer treatment with radioactive iodine, some of these patients have significant gland dysfunction, and so we use the Sialendoscope and to really wash out those glands and try to improve salivary function. So salivary gland swelling that are not due to stones and not due to tumors can often be because of strictures or these areas of stenosis. These can be kinks, or they can actually be physical strictures, and these are probably underrepresented in the published data. And I see a lot of patients that have no stones but have recurrent swelling, and these often affect the parotid gland and affect women. And sometimes there's no rhyme or reason why this develops, but they do benefit from sialendoscopy, and I sometimes give a guarded prognosis for sialendoscopy for some of these patients. But most of the time, 9 times out of 10, they come back and say, I feel so much better having had that procedure because it really opened things up. There are many adjuncts for patients that have stenosis. You can do just serial dilation with larger scopes, or you can do balloons. Here, there's tiny balloons that can actually fit through the scope. And you can do stenting. Here's a visualization of a stent here in the floor of the mouth that we can place, and we suture that in. Patients don't love having that stent in because it rubs on their tongue a bit, but if you can keep that in for a week or two, it actually makes a big difference. And then probably the most valuable thing is actually just flushing the gland with saline and just getting all of the debris and gunk out of their gland. They feel a lot better. Steroids are often infused. I often use Kenalog. It's a steroid that infuse the gland with steroids as well, but you don't have to do that. But there hasn't been much benefit to steroids versus saline in these patients, but I would say that in chronic inflammatory processes, I often use steroids as an adjunct for them. The interesting thing is that you would think that maybe these would recur a lot, but 80% of these patients only need one procedure, which is really wonderful. So with the last couple of minutes that we have left, I wanted to talk about some future directions that we're doing at UPMC. So we're really trying to incorporate patient-reported outcomes. So it's one thing to binarily remove a stone or not, but sometimes that's not the whole story. We need to track patient outcomes and make sure that we're really affecting patients' lives and really showing value to what we're doing beyond just radiologically, or just saying we removed a stone or we did the procedure, so we're happy and that's it. So we need to study it better, and so we're using patient-reported outcomes in our patients pre and post operatively to make sure, and long-term to make sure that we're doing a good job for patients. Multidisciplinary care clinics, we've established a rheumatologic pathway, especially for Sjogren's syndrome, with thought leaders in the rheumatology department. They're already partnering with ophthalmology, and so it's a natural progression for us to kind of all be together with the eye and ear, and really take care of patients in a multidisciplinary one-stop shopping type of scenario. So their clinic currently exists at Mercy, and we're talking about how we can incorporate otolaryngology as well. In-office procedures, this is something we'd like to do more of as our Shadyside space gets built out and have more procedural space. We're discussing trying to do more in the office, which would save a patient a lot, and I'll explain that later too. And then doing multi-institutional research. So right now we're trying to study these combined hybrid approaches to the parotid stones. And so we have about 10 institutions sending us data to see if we can publish on what would be the best practices for these parotid gland stone removal. So here's an example of a salivary gland quality of life assessment. This is a test called the SPIT, or the obstructive salivary problem impact test. SPIT just sounds better than all of that. And so the patients take this quick survey of their symptoms, and we can track how they're doing, and we'll be using this a lot. This is being used in a couple institutions, and the the first paper on the originator for this, and the SPIT questionnaire was also co-authored by Dr. Shakin. And so I think we're in the mix of really being on the forefront of patient-reported outcomes. In-office procedures are great. If we can do a lot of the same things that we could do in the operating room in the right patient in the office, it saves a lot of time and money. So it was a study done by a group out of UNC, and they showed that the procedure times were so significantly different between the two groups because of the time to go under anesthesia, time to wake up, the time of the actual procedure itself, the post-procedure time for to have the anesthetic wear off. So they amounted to be 40 minutes versus 276 minutes for the patient. All this time is not for the surgeon themselves, because to be honest, you could be a lot of this stuff is not when the surgeon's actually operating. The surgical time is not hugely different. It is different in the operating room, maybe because of bias about who went to the operating room, but overall, it's a huge difference for the patient for 40 minutes versus 276 minutes. And I think that we really should be taking into account in the right patient who can tolerate an awake procedure. And this is for not just for washing out the gland, but actually removing stones and and some of these more complicated procedures. You can't do the hybrid procedures where you open a facelift incision and things like that in the office. And so those still have to be in the operating room. But some of the smaller stones that we are trying to remove with the endoscope, I think we should be trying to do that in the office. And then cost-wise, it's just a no-brainer. The amount of cost that it takes to run an operating room plus anesthesia, it's just a huge difference. And this paper really just describes the $9,000 versus $550. So it's a pretty stark difference between the two. But we should assume that based on just the cost that it takes to run an operating room. So back to the case that I originally presented with that gentleman with multiple stones in the submandibular gland. So we actually removed his stones with the Sialendoscope, and this was the what I sent to pathology. So innumerable stones were retrieved. So once we started taking one out, more and more started coming into the view, and they started coming out in rapid sequence. So I could probably count at least 20 stones that we removed from this gentleman, and he's still doing well, and he's enjoying eating without having his gland constantly being swollen, and he doesn't have the scar or the facial weakness or any of the repercussions of a gland excision. And so we're thankful for this technology. We can use the Sialendoscope safely and effectively. It has been developed over 25 years on the shoulders of giants, and it can be used as part of a combined approach as a primary modality. And I think we can really improve the quality of life for our patients, not only with stones, but with chronic diseases. And like I said, a lot of these patients just need one washout with the Sialendoscope, and they feel a lot better. So I think that we are trying to push the envelope here at the University of Pittsburgh, and I really thank you guys for listening. And I know that was a lot to cover in 40 minutes or so, but I wanted to open it up for questions if anybody had any.
Dr. Sridharan, thank you so much. We have a couple questions coming in, and because we were running a few minutes behind in the beginning, I didn't get to say submit questions to the Q&A button. And we also have some patients who sent us some questions in advance of the webinar too. So let me get to the ones we've just had come in, and thank you so much. Are there any dietary habits that have been found to contribute to the formation of stones in the salivary glands?
Not something that I counsel patients on. I assume that this is something that would be hard to study because the incidence of stones are much higher than the incidence of symptomatic stones. So it's hard to know, and I haven't found a rhyme or reason in my patients or in the literature that says that you should avoid certain types of food. I will say that in some patients, we need to check for a systemic problem, like hyperparathyroidism, because if you do have a predilection to getting stones other places, like ureteral stones, kidney stones, things like that. I think that we have to make sure that there's not some kind of underlying process at hand. So I do sometimes get a parathyroid hormone level, but I don't counsel them on their diet except for increasing hydration, because when you do get dry, you can have thicker saliva. And so if you have a stone that's partially obstructive, not causing symptoms, it can go from a partially obstructive to fully obstructive situation.
What is the likelihood of cancer of these glands?
The cancer is unlikely when there's repeated swelling. So if somebody has repeated swelling with meal times, I rarely think that is likely to be a tumor. There can be a tumor that obstructs the salivary gland that has symptoms like this, but that's pretty rare. And usually patients with masses present a little bit differently. They present with lumps that are palpable and stay the same or increase in size over time, or they present with pain that's constant, not with meal times. So when you have like an obstructive type of, like basically if you clog the pipe and you have this backflow problem, and it's periodic, then it's much more likely. But part of the differential is to be a good doctor. We should never just assume based on the symptoms. So we get the imaging, we do the thorough, physical exam and history taking, and I have that ultrasound in my office. I just put it on there and also, double check things to make sure I don't see a mass.
Thank you. So you haven't mentioned cancerous tumors or the effects of radiation therapy on salivary glands. Are we going to talk about that another time?
Well, that's exactly something that I'm very interested in. So I recently took a patient that had radiation fibrosis to the operating room and did a irrigation of their gland. And I still have not found out how they're doing because it was just last week. But I want to see how they're doing. But when I put the camera in, I saw a lot of fibrotic changes. I saw damage to the actual duct that was caused by the radiation. And I can see why people have salivary dysfunction, because when I put the scope in, it was clearly obvious. So this, I'm sort of, putting the cart in front of the horse here. But I have been tinkering with an idea of a research a prospect where we intervene on glands during radiation. So while patients are getting radiation, could we introduce a Sialendoscope, especially if we could do it in the office? So they come for their appointment, I see them, do a washout of their gland and see if I can do something to protect their glands, because a lot of the effect of what's happened to their glands is not really reversible with just flushing the gland after the downstream effect. So maybe a preventative measure, during radiation or even before radiation would be more ideal. I have also wanted to introduce the idea of salivary gland transposition, which is a topic that's done in Canada. It's a procedure where you actually take the gland while you're doing surgery on the patient, when you don't have to remove the gland as part of the cancer operation, and you move the gland to a place where you know the radiation is not going to be the strongest. It's impossible to not get radiation at all to in the head and neck region and move it to a place, but sometimes you can transpose the gland to a different location so that you don't get the full brunt of the radiation. Maybe you don't have the same effect. But your thoughts are my thoughts too. Now that I'm doing a lot more Sialendoscopy, I said, can we intervene on patients during radiation? And so I'm thinking about how to do this. And I'm really kind of probably saying too much because I'm still in the formulation part of this. But you're right. I do care about radiation induced fibrosis of the somatic and dysfunction. But this has not really been, there's not really good published literature on how this helps patients with radiation, if that answers your more direct question.
Thank you. So we hear about tonsil stones, we hear about kidney stones, and we have salivary stones. Can you talk about the differences between all of them with the material that's formed?
Yeah. Well, I think that the tonsil stones are going to be a lot different because those are basically food that's been impacted and just gets hardened, like almost like petrified, and they taste so bad because they're basically like decomposed food that is turned into a rock, so that's quite different. These are like
Charming. Yeah.
so these stones are more in line with the kidney stones in that they're these hydroxyapatite and made of these minerals, and so relatively comparable, yes.
Okay. So do salivary stones hurt?
The actual stones don't hurt. It's the sequela. It's what happens when you obstruct a gland. But just having a stone doesn't hurt. A lot of people have stones that we just don't know about. I've got patients sent to me because the dentist has been doing a panorex, like a regular X-ray, and sees something. So they send it to me, and I say, the patient has a stone. I'll send it to Shaum. And so I see the patient. I say, do you have any symptoms? And they say no. And I say, well, you could develop symptoms. There's no understanding of the natural history of whether you will develop symptoms, but just because you have a stone doesn't mean you have symptoms. It's really the plugging of the gut.
How many times in a week, are you getting people sent up to you for salivary gland biopsies, which is really the gold standard for determining Sjogren's?
Yeah, so I would say between me and Dr. Johnson still likes to do salivary gland biopsies. So between us, I think we get probably one a week or so.
Mhm.
But this is going to increase too because there's a new sort of, uh, I'm not sure exactly her title, but she's going to be the main Sjogren's disease sort of um, overseeing Sjogren's care within the
Mhm.
rheumatology department. Her name is Rachel Gordon, and she and I have been formulating different ways, different pathways for patients. So it's going to get more and more. She is partnering with ophthalmology and has them in her clinic, or they have a joint clinic. So it's really nice for diagnosing and for multidisciplinary care for patients. So it's been really nice, and I've done not just minor salivary gland biopsies, but major salivary gland biopsies for her to rule out disease. Sometimes you can also miss a lymphoproliferative, like a cancer formation within chronic
Mhm.
disease. So we have to always be on our toes.
Do you ever get referrals from, well, I'm sure you do, dentists who are seeing things not just from rheumatology or PCPs? I would think dentists would be sending you a lot of people as well.
Yeah, dentists, primary care doctors, other otolaryngologists. It just most people don't have the equipment. Most people don't have
Mhm.
the don't want to dabble in this technique, and most people don't have the patience. You have to be a little patient for this because as you can tell, it's like you have to do things slowly and methodically and get these dilators in and then get the scope in. So it takes some practice, and it's fun. I like it. It's rewarding, but a lot of people veer away from it immediately.
Very minute and yeah. Well, that is it for today. We're almost to the top of the hour. Anyhow, I really want to thank you and our speaker, Dr. Sridharan, and all of you for joining in. We'll see you in 2 weeks.